So many thanks for the invitation to participate. I'm an adult neurologist, epileptologist, and specialist in EEG, including intracerebral EEG. I work in Marseille, France. So to think first about historical perspective, in the ancient world, we can recall that hysteria and epilepsy were not distinguished. And then later in the Middle Ages, a supernatural cause was often suspected for these types of events. And it wasn't until the late 19th century that Charcot and colleagues carried out the first scientific studies of hysteria. And importantly, at this time, the first mechanism of dissociation was proposed. And it was in the 1920s and 30s that the first EEG recordings allowed neurophysiological distinction between epileptic and non-epileptic events. And then from the 1970s and 80s onwards, the first long-term video telemetry recordings allowed analysis of habitual events. And it's at this point that the term pseudoseizures first appears in the literature. And over the last 20 years, there have been quite important advances in our understanding of the neurological basis of psychogenic non-epileptic seizures. And in parallel, the psychiatric classification systems, including this category, have greatly evolved. And these neurological changes in patients with psychogenic non-epileptic seizures show abnormalities in various brain networks. And this has been shown both in the resting state, the period between events, using multimodal approaches, including EEG, functional MRI, PET scanning, and also more recently during episodes using, for example, ictal SPECT and intracerebral EEG recording. And so while this is clearly a disorder involving psychological disturbance, there are nevertheless clear signs of brain disturbance associated with this. And of course, this condition falls at the interface between neurological and psychiatric models of illness. And probably for the time being, the psychological models are more developed relatively than neuropathophysiological models. And this contributes to the difficulty in trying to find the right name for this condition. So does it matter what we call it? Well, it's obviously important for medical colleagues, for other paramedical colleagues, for the patient, their family, the general public. And in general terms, any medical condition is usually named based on the cause of the condition or its clinical presentation or combinations of these. So if we go through some of the names that are used, the most common one currently, psychogenic non-epileptic seizures, clearly conveys a psychological origin. This has been proposed as part of the definition of the condition. It also conveys that the events are not epileptic. I think it's worth mentioning that in English, the word seizure usually tends to imply epileptic seizure. But this is not necessarily true in other languages, in which the word for seizure can mean any kind of acute or paroxysmal attack. Dissociative seizures, now this implies a psychological mechanism of dissociation, but I'm not sure that that's true for every case, remembering the great heterogeneity of presentations of patients with this condition. And I'm also not sure that everyone would know what this means, notably colleagues perhaps in the emergency room. It also doesn't clearly clarify that seizures are non-epileptic, and of course it keeps us at the psychological level of understanding of the disease rather than the physiological level. Next, functional seizures. So lots of interest in this term, notably to distinguish this condition from the so-called organic neurological conditions. I have a little bit of trouble with this term as an epileptologist working with EEG, because for us, any condition investigated with neurophysiological techniques is by definition a disorder of function. And for example, an epileptic seizure is a transient disorder of brain function as is the case for migraine, for some movement disorders, so that while I understand the interest of this term and of course the usefulness of bringing PNES closer to other functional neurological disorders, I have a little bit of trouble with the accuracy of this definition. Pseudoseizures, this term now is much less widely used, and of course it can carry this connotation of something that's fake or even simulation, and it's clear that this term is less favourable. Non-epileptic attack disorder was in vogue for quite a long period. It tends to be quite non-specific. At least it does convey clearly that the events are not epileptic. I would say there are relatively few strong arguments against or for its use. So we said earlier that the name of the condition in medicine often reflects the cause of the condition, and clearly here we're in difficulty because we don't yet understand the cause, the mechanisms of PNES. And as I mentioned earlier, one of the difficulties is this mind and brain dualism, where we separate into two medical specialties these two different aspects of nervous system functioning. We can think about the nervous system disorders at different levels, and the psychological, psychiatric, or behavioural level, which we could think of as the mind model of disease, falls within this cognition and behaviour level. And I think the term suggested for these episodes, functional seizures, dissociative seizures, relates to this level, whereas the move over recent years to trying to better understand the cerebral pathophysiological changes associated would tend to fall more within the brain model of disease, which is at a lower level of systems, areas and circuits. And we don't have yet a name that's clearly related to this level, but non-epileptic seizure is perhaps the closest. And ideally, we would be looking to try and bridge this gap between the two aspects, which is rather artificial. And at present, I would say that while psychogenic non-epileptic seizure is certainly an imperfect term, it does, however, tend to communicate the knowledge of the condition as we can best currently describe it. So I'll finish there. Thank you very much for your attention.